that some current issues I'm going to discuss about the bronchial asthma. Now, the first question, what is asthma? First, I'd like to show you the previous year's definition, which possibly explains what is asthma. If you understand these lines, this was the Global Initiative Against Asthma. This is GINA guideline. GINA guideline has been updated in 2023. I will share with you. But this is the GINA 2008 gave this definition that asthma is a chronic inflammatory disorder of the airways in which many cells or cellular elements play a role. Chronic inflammation is associated with airway hyperresponsiveness, chest tightness, coughing, particularly at night or in the early morning. These episodes are usually associated with widespread, but variable airflow obstruction. So hallmark of asthma is airflow obstruction, variable airflow obstruction with the lung, which is often reversible. That is another hallmark of asthma, either spontaneously or with treatment. Sometimes it happens spontaneously. Many of the, treating physicians, many of the doctors, they take help of this spontaneous remission. So spontaneous remission is known in asthma. So that definition, to me, when I read these lines, I understand asthma very clearly. But you know, GINA 23, which is latest guideline of asthma, defines more or so same definition, but it's not so elaborate. Asthma is now they say asthma is not one disease. It's a heterogeneous disease, usually characterized by chronic airway inflammation. That remains the same. And it is defined by history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, that vary over time. So variability is still retained, is still a gold standard in intensity, together with variable expiratory airflow limitation. That is the airflow limitation. So this is literally an obstructive airway disease. Classical example. What are the risk factors of asthma? Usually, you know, asthma is predisposing factors in the development of asthma is genetic element. So many times you have such gene, like family history of asthma decides that whether we are going to get asthma or not. And the second element is atopy. Atopy is a propensity to produce abnormal amounts of Ig against the exposure to the environmental allergen. Appears to be strong identifiable predisposing factor for asthma. So atopy is one of the factors. And so what are the triggers which precipitate asthma? Usually it is if it is allergic asthma, it is the air allergens, it may be indoor allergens, maybe outdoor allergens, occupational exposures, weather conditions, respiratory infections, especially viral one, exercise, hyperventilation, exercise-induced asthma is also known, food, additives, drugs. So many things can trigger the attacks of asthma. How much is the problem? You know, globally, it is estimated around 400 million people, they suffer from asthma globally. In India also, it is estimated that it is variable, but it is estimated that about 65 million patients. So there's a large number of patients of asthma globally as well as in India. Second thing is, you know, if you see the asthma, I see is a chronic disease and treatable disease. It's not a curable, it's treatable disease. patient can lead a normal life. But level of the asthma control in India, in one of the studies says that control is very, very minimal. Most of the patients are about 29% are well controlled, about 60% are somehow controlled, and rest they are poorly controlled. 7% are poorly controlled, and 2-3%. So what I'm trying to say, although the management is there, but most of the asthma patients, when they are studied, they are only about 30%, one third them are they are well controlled, and percentage well controlled as per. Then another thing you have to understand: nobody should die of asthma today because we have a very good drugs, anti-inflammatory drug, which can control the inflammation of asthma. But unfortunately, around 461,000 deaths globally occurred every year, and in India, is around 80,000. About 43% of the death is in India. So what I'm trying to say that it's so death also, asthma also kills, although it should not kill. Poorly controlled severe asthma is one of the major reasons for asthma-related deaths. And lastly, it has been worked out lately around deaths, asthma deaths occurs in India around not just 80,000, but it not in 1 lakh, but it has reached nearly 2 lakh, and it is only that because of the poor control of asthma. So major factors for asthma morbidity and mortality you've seen is the underdiagnosis and inappropriate treatment. Many times, sometimes it is overdiagnosed. There is no asthma, and for people diagnosed as asthma. So one thing is very clear till this time, that it's a chronic disease, and it has a lot of morbidity and lot of mortality. How to diagnose asthma? Diagnosing asthma is not very difficult issue. You just, history is very important. If you take patient history, you can diagnose asthma very well. In history, what you'll get shortness of breath, wheezing, chest tightness, recurrent cough. And then apart from these symptoms, which is variable, and usually asthma starts from early age. And what are the helpful additional history points? Personal history, family history of asthma is very important. Recognize triggers you have to find out from the history. Pattern of severity of symptoms and exacerbation, history of worsening after drugs like aspirin or other NSAIDs, beta blockers, that you can elicit from the good history. And signs, after the history, you took the history, what are the signs? Signs you should understand that suppose asthma is in a remission phase, he is well controlled, you may not get any sign, just history will be there. That's why in sign I just stop on none. But otherwise, if asthma is an acute exacerbation, there you will get wheeze, diffuse, bilateral expiratory wheezes, and patient may be tachypneic. And how to confirm them? If these 3 groups of points are there in the history, then how to confirm? Confirmation comes from a good spirometry or by peak flow meters. In peak flow meter, if more than 20% diurnal variation over 3 days in peak flow meters are there, and if you find that FEV1 and is more than 15% after short acting beta 2 agonist, it means when you do spirometry, you find ratio of force expiratory volume to force vital capacity is around less than 70%, you say there's airway obstruction, and then you can, if you could demonstrate reversibility, then it clearly confirms that yes, you are dealing with the bronchial asthma. Now, then next few slides, how asthma is treated. And that you have to understand, it's a big subject, but it's still, this is a global initiative for asthma. In short, we call it GINA. And the last guideline was revised in 23. Every year, this guideline is revised. So I'm going to share some of the facts mainly from 23. And when you manage, what is your goals? Goals are very clear. Achieve and maintain control of symptoms. This is the first aim. If anybody comes to us as a doctor, our first aim is to achieve control of the symptoms and maintain that. Maintain normal activity level, person able to do normal routine things. Maintain pulmonary function as close to the normal as possible. It should prevent, good treatment should prevent asthma exacerbation. And it should also avoid the adverse effects from the asthma medication and prevent, ultimately, it should prevent asthma mortality. That I said that nobody should die today of asthma. So these are the goals which have been set up for a successful management of the asthma. And what are the usual issues in asthma management? The first issue I would like to touch upon, patient-doctor relationship, partnership, whatever you call. You call it counseling, whatever you say. That is the most important in asthma management. And patient-doctor partnership, what it means? It is a continuous process which provides the patient family suitable information and training so that the patient can keep well and adjust treatment according to medication plan developed in advance with healthcare professional. So you have to, there should be a good partnership between patient and their family members and doctors, treating doctors. That is what is meaning by patient-doctor. So education is one of the essential components. I have seen patients not taking drugs properly, not taking inhalers properly, and this is only because of there is no partnership. There is a poor partnership between patient and doctor. So that is the first very essential step I just emphasize on. And then what should be your curriculum for patient education? And curriculum should be avoid risk factors, take medication correctly, understand the difference between there are two types of medicine, controller and reliever. Controller means which affects which controls the inflammation. Reliever means immediate symptom relief. And say for example, best controller is inhaled steroids, and best reliever is inhaled bronchodilators. Monitor their status using symptoms if available, and recognize signs and asthma in worsening or take action, seek medical help as appropriate. So all these points should be there in your patient education leaflets. The next point is, next issue in asthma management is identify and reduce exposure to the risk factor. No fun in giving drugs and drugs unless you identify and reduce the exposure to the risk factors. To identify and reduce exposure to the risk factors, methods to prevent the onset of asthma is hardly available. But measures to reduce exposure to causes of asthma exacerbations like allergens, foods, medicines should be implemented whenever possible. So I know that complete avoidance is very, very difficult, but at least you can reduce the exposure. Like somebody has allergy to dust, so you'll take measures which can reduce the dust exposure. Reduce exposure to indoor allergens, avoid tobacco smoking, avoid vehicle emission, means pollution, identify irritants in the workplace. If there's some irritant in the workplace, you have to identify and explore role of infection on asthma development, especially children and young adults. That is, what are the risks? These are the risk factors. Then third issue in asthma, when we manage asthma, is to assess, to treat and monitor. Assess, treat and monitor. And when you do the assessment, what you assess? First, you assess asthma control, whether a person is on drug or not. What is asthma control? Assess symptom control over last 4 weeks. Assess risk factor for poor outcomes, including low lung function. And then treatment issues. What you will assess in the treatment? Every time patient come, you check inhaler technique and their adherence, whether a person is taking or not taking. Ask about the side effects. Does the patient have a written asthma action plan? And what are the patient's attitude and goals for their asthma? So what patient want, that also you have to assess. And you have to assess the comorbidities. If something, suppose asthma and there are other comorbidities. Example being, if there is a rhinitis, you have to manage rhinitis also. Suppose there is a gastroesophageal reflux disease, you have to. Obesity, obstructive sleep apnea is one of the important comorbidity, depression, anxiety. So all these issues you have to assess in your particular patients, whether he having some of the comorbidities along with bronchial asthma. And these may contribute to symptoms and poor quality of life. So assessment of asthma control, assessment at what level he is, then treatment issues, and then comorbidities. And symptom control, the latest way of assessing is, these are the simple 4 questionnaire. Daytime asthma symptoms, more than twice a week, any night awakening due to asthma, reliever needed for symptoms, whether you need rescue medications or not, more than twice a week, or any activity limitation. These are the 4 questions on which you just have yes or no. Suppose a daytime asthma symptom more than twice a week, tick yes. If no, no. So all these, any night awakening due to asthma, yes or no. Reliever needed to control more than twice a week, yes or no. And any activity initiation, any activity limitation due to asthma, yes or no. And if the well-controlled asthma will be known as well-controlled, if none of these will be there, partly controlled if 1 or 2 of them are there, and uncontrolled if 3 or 4 or more are there, then you can say uncontrolled. That is how you assess today asthma symptom control. Treatment of asthma, in adults, there has been certain changes in recent years, and which as well, first you have to understand, I was talking about what are the controller medication, what are the reliever medication. Now, reliever medication, I'll talk first, but they are the rescue medicine. Like somebody had a fever, you give paracetamol, but then you have to find out the cause and then you get the proper treatment. So here, reliever medication is a rescue medication, like rapid-acting inhaled beta-2 agonist. You must have a salbutamol, terbutaline like drug. Inhaled anticholinergics, short-acting oral theophylline, short-acting beta-2 oral agonists. So lot of reliever medications are available today, and most of them are available in the inhaled form. Although there are also some of them are also available in oral form. And what is the controller? Controller means, as I said, it is an chronic airway inflammation. So controller, so idea you have to understand, between reliever and controller. Reliever, you think of giving SOS, not every time. Reliever is not drug of choice. The drug of choice is a controller medicine, and which will control the inflammation. And it should be very clear from this chart, the controller medicine should be given priority and should be given regularly. Like inhaled or systemic steroids, leukotriene modifiers like montelukast and other drugs, long-acting inhaled beta-2 agonists in combination inhaled. This is a very common form of treatment available. Combination of long-acting beta-2 agonist and steroids. Sustained release theophylline, chromins nowadays and they're not available. Anti-IG, IL-5, IL-5R, these are the biologicals which are available, may be required in very small percentage of severe asthma cases. Other systemic steroid sparing. This is how you divide between reliever medication and controller. The next question comes, what should be the route of administration? Initially, now it is very clear there are three routes: inhaled routes, oral routes, and parenteral routes. Ideally, between these three routes, inhaled routes is the preferred route. And oral and parenteral, they are not preferred, but in case of emergency, parenteral routes are preferred. So, but routinely, management of asthma, the inhaled routes is a choice. Why it should be choice? Because inhaled routes, drug directly goes to the lungs, very small dose is required, and onset of action is also very active. And then side effects are also very less. So because of all these positive points, choice is inhaled drugs. Now, user of spacer, when you're using inhaled steroids, then usually we advise you should use spacers. There is a chamber reservoir where the actual aerosol can help prior to inhalation, and it is recommended, especially with problem with coordination, children, when you are using high dose inhaled steroids, acute asthma, during acute asthma, you have to use this spacer. So spacer is preferably, because when you use a spacer, the amount of drug deposited in the lungs is much high if you don't use the spacer. So that's why there are many advantages of spacer, overcome coordination problems, and deposition is more, systemic side effects are less. So that is the advantage. Then again question comes, which device? We have multiple devices. Multiple device, find a nebulizer, meter dose, MDI, dry powder, it may be unit dose, it may be multi-dose, breath-actuated inhalation devices. There are a lot of devices are available. I'll not go into details, but the correct choice of device is prerequisite for successful. I say that what I do, I show the patient all the devices available today. And I ask the patient, because patient might have used these devices before coming to me. So what I say, which device you are comfortable. Although there are certain parameters, but I think it's a cafeteria choice, and whatever patient is more comfortable, if you spay. But otherwise, if the age is less than 4, it is the PMMDI, means inhalers, and 4 to 6, it is PMDI plus spacer, and there was in children it was with face mask. And if age is more than 6 years, then you can use any one of them: dry powder, breath actuated, PMDI, anything with spacer, without a spacer. An alternative is nebulizer. If somebody is not able to use this, then now the nebulization is very often used. And one thing you have to understand very clearly, that asthma control worsens as a number of mistakes in inhaler technique. And for your information, it is very clear. If you don't consume the inhalers properly, correctly, then naturally there should be no symptom control. You're wasting your money. more incorrect the technique and more uncontrolled will be the disease. And we did a study way back in 2002 and published that, about only correct techniques were used by 10%. That was a little old study. And recently we again saw that it's still about just 28% people are taking inhalers correctly. So what I'm trying to say, you have to have a partnership between patient and doctor and their relatives so that he understands, and every time he comes, you have to make explanation. And in asthma, usually we talk of step care management. And when I say step care management, before that, in 2019 GINA guideline, there was a landmark decision, landmark changes in asthma management. Initially used to give the salbutamol, rescuer medication, initial stages. But now it is very clear you will not use rescuer alone. Whenever maybe disease is very step one, whenever you are going to use in this medication means rescuer, along with rescuer, you have to use the inhaled steroids in low doses. That is the basic change has occurred in GINA 2019. And then GINA 21 has created another change. Initially, we have only one track in step care management. Now we have two tracks in step care management. Track one means with low dose ICS and formoterol. Bronchodilator here is a formoterol. ICS could be anyone as the reliever and as the rescuer. Both you combine together. And same thing you will use as reliever also. This is known as MART therapy. So, then track two is, so in track one, same inhaler which contains ICS, inhaled steroids plus formoterol. Bronchodilator is a formoterol. Same reliever, and then if somebody you want to increase, then same inhaler can be used as SOS medication. But in track two, short-acting bronchodilator like salbutamol, they are the reliever. But this is an alternative. Choice is today track one. And you know that stepwise, if you see, this is GINA 23, stepwise treatment, step one and two, you use as needed only low dose inhaled corticosteroid and formoterol. That is a track one. And as a reliever, as a rescuer, you use the same inhaler, means ICS and formoterol. And likewise, as the symptoms increases, you go ahead, and ultimately, if symptoms are not being controlled, then you increase the dose of steroids. Then if it is not controlled, then step 5, you can add long-acting antimuscarinic, like many drugs are available today. And then you must refer the patient for assessment, and you might use in some of the patients who are uncontrolled, you use a lot of biologicals which are available today. And then in a track two, what happened? Same type of treatment, but there the formoterol is not must. Any bronchodilator you can use, but then in the reliever, what you have ICS and SABA. So no alone SABA. That is the rule has short-acting bronchodilator because in previous guidelines reliever was SABA medicine. But now SABA, even reliever also contains ICS and SABA, unneeded basis. And usually, how you select the drugs. In India, people don't report in step 1, step 2. What I have seen, they report at a very late stage. So they step 3, 4. So what usually the selection of the drug is current level of control, patient current treatment, pharmacological properties, availability of these drugs, and economic concern. All consider you, then you decide. And maximum, usually what I do, as I maximum treatment initially, then usually I decrease the medication. Otherwise, what word says is step up, I say that because of our condition, we use maximum treatment so that you have to control and then reduce down. How often asthma be reviewed? Usually 1 to 3 months you review, and then stepping up asthma treatment. If symptoms are not controlled, you may step up, and short term and day-to-day adjustment is. And if asthma is very well controlled for 3 months, then you can think of reducing the drugs. And general principles for step down is to just you have to the lowest dose that controls the asthma symptoms and exacerbation, minimize the risk of side effects. When to consider stepping down? When symptoms have been well controlled for at least 3 months, no respiratory infections, and prepare for record the level of symptom. Make sure that patient has written asthma plan, book a follow-up visit 1 to 3 months, and step down. Usual formula is, I'll not go into details, you step down the inhaled steroids, reduce by 25 to 50% every 3 months. Then question arises, are you able to stop? As I said, this is a chronic inflammatory disease, so it is very difficult to completely step down the inhaled steroids. Studies has proven that if you stop inhaled steroids, patient may again get symptoms. So usually, as I said, it's a chronic, I say it is a lifelong treatment, but then adjustment, stepping up and stepping down is possible. However, 2-3 slides about immunotherapy. A lot of things people talk about immunotherapy. Now, what Gina says, what word says that asthma constitutes a relative rather than absolute. There is indication. Some of the patients, they may get immunotherapy. Greatest benefit has been obtained in the treatment of allergic rhinitis. And Cochrane review has already shown that you can reduce symptom score, medication score, and improved hyper-responsiveness. Immunotherapy is usually considered in a well-assessed. It cannot be done by everyone. It is done by the specialists who are trained in immunotherapy. Strict environmental. It should be well assessed. It should be practiced in well assessed, selected cases of asthma only after strict environmental avoidance and pharmacological intervention. Not that the only thing is immunotherapy, including inhaled steroids, have failed to control asthma. Should be performed only by a trained physician. So immunotherapy may be one of the choices in certain individuals who are allergic in nature, like take the allergen-specific immunotherapy. Now there are 2 types of when you give these antigens in gradually increasing doses, and there are 2 types of immunotherapy now available. One is subcutaneous, another is sublingual, and most common allergens included in immunotherapy are dust mite and grass pollens, and against fungus there is very little evidence. And usually in asthma, what we say, if patient is allergic in nature, and patients who do not present a severe disease, FEV1 is more than 70% after adequate treatment, symptoms not adequately controlled by avoidance and pharmacological treatment, have both bronchial and nasal symptoms, and do not wish to be on long-term. Many patients, they don't want to be long-term treatment. And pharmacotherapy, when pharmacotherapy is producing undiagnosed. These are some of the indications where we think of doing allergy testing and giving hyposensitization. Another way of treating nowadays is a bronchothermoplasty. It is available at very higher centers in India also. And what bronchothermoplasty is, a procedure that delivers a thermal energy to the airways via bronchoscope to reduce the excess airway smoke muscle and limit ability to constrict the airways. Outpatient hospital procedure usually done over 3 sittings, complementary treatment. It's not only treatment, it's a complementary treatment. And treatment options shown to increase the level of asthma control, but still a lot of studies are going on. Hardly anything is final. But some of the centers, they are practicing. It's difficult to treat asthma. What is the role of complementary medicine? Although so many countries, traditional method of healing are used, but their efficacy has yet not established very clearly. And their use is somehow. People ask me about what about fish therapy? A lot of people go to the Hyderabad fish therapy, but again, it is not a very scientific. Because, this is one of the statement from Hyderabad itself, a very famous doctor said fish medicine is says asthma expert. So these are the methods which have to be, if being employed with caution, and hardly any rule has been established. So I have come to end of my presentation. There's two concluding remarks if I want to give. That asthma, you have seen, can be effective. It's a chronic inflammatory disorder, which is a chronic inflammatory disorder, probably requires a long treatment, and I say probably a lifelong treatment. But you should feel happy that effective asthma management programs include education, objective measures of lung function, environmental control, and pharmacotherapy. A stepwise approach to pharmacological therapy is recommended, and anything more than mild occasional asthma more effectively controlled by suppressing inflammation. Now everywhere, even in small anti-inflammatory required, availability of various cultural preferences, differing healthcare system should be there. And one thing I would like to say, whenever you treat asthma, you just understand patient background, their financial status, what he is cooperating, what he can easily do, and then with effective intensive counseling and partnership with the patient and family members, asthma can be very well controlled. Let me say, many of my patients I'm treating them last 40 years, they are very effectively controlled, and they are doing their duties, whatever they wanted to do, they are doing. But only thing I say them, please don't stop the drug. By your own, we will assess and whether we'll step down, whether you'll be able to step down completely or not, that decided by us. So with this, I would like to say that history is a very important. I have a lot of YouTubes on like history taking, physical examination. Some of you are interested, you can go through. I have one lecture on auscultation, and then we have lectures on how to interpret chest X-ray, and then we have book on a clinical allergy, and chest X-ray book we have lately come, and it is available in Amazon. We have Yoga and Dhamma, and my future book is already there on asthma. And I would like to end my presentation by saying, anyone who keeps learning stays young. This is a very famous saying. And with this, thank you very much.